Thank you, Mariella. I am so delighted to be here. I really am. When Mariella first mentioned this conference years ago to me, I think at Low Carb Denver, I had told her then, anything I can do to show support for Israel, I'm happy to do it. So thank you again for inviting me. I'm very happy to be here. And is Pazit here? Pazit, did you come? Oh, thank you again. She was so patient. I've been in these clothes for about 70 hours. And unfortunately, the great tragedy of not having my luggage is I lost all of my hair care products, but I think I'll be okay. Thanks again for the invitation. I'm delighted to share with you some thoughts about insulin resistance and its relevance in disease. And I have this bold title, Why We Get Sick. And Mariella was so nice at actually translating the book into Hebrew. And I named this talk Why We Get Sick because I know that if I named it Insulin Resistance, Why Does It Matter, no one would care. Now, you would because you know so much, but because you know so much, I hope this isn't too redundant. All right. You guys, I'm clicking this, but it's not going. Okay, now we're rolling. Now, it's interesting. I'm from the state of Utah. That's where my university is. And you here wouldn't know this, I don't think. There's no reason why you would, because I'm so obsessed with Israel. I do know this. On the left is, of course, Israel. On the right is Utah. I believe these are the only two places in the whole world where there is a freshwater lake connected to a salt lake. And in Utah, we call it the Great Salt Lake. It's very, very big. This is to scale. And interestingly, the early pioneers who settled in Utah, the river that connects these two bodies of water, guess what we called it? Jordan. Yep, so it's the Jordan River in Utah connecting a fresh body of water to a salty body of water. Interesting parallel. All right. Now, in addition to these parallels, there are many others that we have around the world, and that is the list of diseases that kill people. Here's that list, generally, of the top 10 killers. And they can shift places a little bit in different countries, but not too much. You'll notice here that I've highlighted diabetes. It's coming in at around number 7. The tragedy with that view is that most people don't die with or die from diabetes, they die with it. There are disorders that the diabetes is in fact contributing to, and in fact is the leading contributor to. So I think rather than putting diabetes further on the list, we need to appreciate that it's essentially driving every other disease, and thus it is important for us to understand. For the people that are translating, is this pace okay? It's a little too fast? I'll slow it down a bit. Okay. I used to translate from English into Russian. I really did. And so I know how difficult it can be when you're trying to translate. Okay, so type 2 diabetes is a disease of concern. It's a disease that we should be focused on. In order to understand type 2 diabetes, we of course need to appreciate the foundation upon which it is built. And the foundation of type 2 diabetes is insulin resistance. Now, insulin resistance has relevance just beyond type 2 diabetes, of course. And that is these big killers, if you will. Heart disease, certain cancers like breast and prostate cancers, fatty liver disease, and then other disorders like disorders of the nervous system, like Alzheimer's disease, and others including things like infertility. In fact, the most common forms of infertility in men and women, erectile dysfunction and polycystic ovary syndrome respectively, are both at their core diseases of insulin resistance. And the association with erectile dysfunction is so strong that researchers who study infertility in men, some of them published a paper a few years ago, and the title was something like, "Is erectile dysfunction the earliest manifestation of insulin resistance in men?" It could be. Now, I've been describing insulin resistance as the villain. I'm telling you a story, right? I'm a professor, and so whenever I'm giving lectures at my university, I'm always thinking, how can I keep 120-year-olds engaged for 2 straight hours? right? It's not easy because they want to look at Instagram or Facebook. And so I'm telling a story all the time. And in this story that I'm telling you, here's the villain. Insulin resistance is the villain, but let's make sure we understand it first. You guys, can I take this out? Okay, oh, this is so much better. All right, so to understand insulin resistance, we need to zoom into the level of a cell. And I'm deliberately saying a cell because we could pick any single cell in the body. Every cell in the body, from brain cells to bone cells and lung cells to liver cells, will respond to insulin in some way. There is no exception to this. And so insulin is very important because of that. So here is any random cell. On the surface of every single cell in the body, there are insulin receptors, these little doors that only insulin can come and knock on. So insulin will come and knock on the door of a cell. In so doing, the cell will respond. It will open the door, if you will, and then there will be some kind of action. I'm deliberately being vague in just calling it an action just because it depends on what the cell type is. Insulin will do something differently at the brain than it will at the blood vessel. So we'll just call it an action. Now, insulin's most famous action, but I will not say its most important. No, that's not true. Its most famous action is that it will control blood glucose. So if we go eat some bagels, which I confess I am going to do because I want to eat some bagels while I'm here. It just seems appropriate, right? It's culturally appropriate to eat some bagels. So we go eat a bagel and our glucose levels climb. If glucose levels stay too high for too long, that becomes lethal very quickly. And so insulin is a hero here. Insulin will come to the door of, say, the muscle cells mostly, knock on the muscle cell door, open the doors for glucose, and now glucose can come from the blood into the muscle. And so we've corrected the glucose. So this is insulin's most famous action. And I'm just showing that here as an example of what it can do. Unfortunately, over time, a cell may stop responding to insulin. So you can see that the insulin action gets diminished. In this instance of controlling glucose, the obvious effect of that is that blood glucose levels will be higher. At the same time, running quite concurrently, if not even before, if one molecule of insulin is enough to get, it's not enough to get the full response anymore, the action is compromised, well then insulin levels themselves will be much, much higher. And now what was once a polite knocking on the door is a mob angrily pounding on the door of the cell, all in an effort to try to restore the action back to what it was. Now, in this long-winded description of what insulin resistance is, there are two essential pieces to this. And they are irrevocably connected. They're inseparable. Yeah, inseparable. You have to have both of these together. The first is that some cells aren't responding to insulin. This is the prototypical essence of insulin resistance, defining it at the level of a cell. A cell isn't responding as well as it used to. But we are more than just a bag of cells, so we have to consider what's happening in the entire body. At the same time, insulin levels are elevated. There is no such thing as insulin resistance without elevated insulin levels. They are two sides of the same coin. You cannot have one in insulin resistance without the other. Now, let's look at this in a different perspective. Here we have the time along the bottom axis of the average individual who's making their way, becoming more and more diabetic. And so glucose levels are going higher and higher and higher. If we superimpose insulin on this, we see a very, very different curve. And now you can see well before the glucose ever started climbing, the insulin had already climbed dramatically. And so I have on here these two time points. The first is known as insulin resistance. And this is so often overlooked, totally undiagnosed, completely missed, because the glucose stays normal. And we have a very glucose-centric paradigm, or a glucose-centric view of metabolic health and insulin resistance and diabetes. And we completely ignore the insulin, but you can see the relevance. If we looked at insulin, we would have detected the problem 10 or 20 years before the glucose ever started to climb. And now when we move into that next phase, now we see true classic type 2 diabetes. which is both elevated glucose, the main thing the average clinician is looking for, but we also see elevated insulin. There is a misunderstanding, it is a myth, that insulin levels become truly deficient, like to zero in type 2 diabetes. That does not happen. You can see that, as I highlighted here, it can drop, but it's still multiples higher than it used to be at the beginning before they ever started the journey. If insulin truly goes to zero, then they've just developed an autoimmune type 1. It just was coincidence that it happened along with their type 2. So the problem with the classic glucose-centric paradigm is that we failed to detect the problem as early as we could because we aren't measuring the insulin. All right, so that's what insulin resistance is. Now, where does it come from? To truly understand the villain, we need a backstory, right? And in understanding insulin resistance, it helps us understand type 2 diabetes. So let's go back to this paradigm for just a moment. I very much embrace the idea that insulin resistance starts in the fat cells. Now, you should know that this is a debated field, that there are in fact meetings at diabetes conferences about which is the tissue that first becomes insulin resistant. I think it's somewhat artificial in the lines we're creating because they all kind of go together. But I nevertheless have a fat first focus of insulin resistance. And then once the fat cells have become insulin resistant, they start spreading this message to other tissues. And I very deliberately, remember I'm a professor and I need the 20-year-olds to get what I'm saying. So everything I'm putting here is very deliberate. I have the fat cells over the first hashed line to show that that's the first one at insulin resistance. And then as we're moving into type 2 diabetes, I have those other tissues. And I'll touch on those very briefly in just a moment. But once they become insulin resistant, now we can't control the glucose very well anymore. And now we've moved from insulin resistance into full type 2 diabetes. All right, now, the causes of insulin resistance. Just to lay some common groundwork or common understanding here, I use the term primary causes and secondary causes. For the sake of time, I'm not going to go into the secondary. I'm already going too slow here. But when I say that a cause of insulin resistance is primary, I mean that we can cause insulin resistance in isolated cell cultures in a petri dish, or in laboratory rodents, or in the pinnacle of all of God's creations, humans at the very, very top. And everything in between, we can cause insulin resistance with chronically elevated insulin, with stress, and with inflammation. Now, I'm just defending these views by just citing, anytime you see a PMID, that's just a PubMed identification number for a citation. And anyone's taking pictures, you can just literally put that in a web browser and the paper will come up. So these are three primary causes. I've actually published papers on all three of these, so I say this with some degree of authority. But I can take cells or rodents or humans, elicit changes in any of these and cause insulin resistance. Now, because I know I have Rick Johnson here, Rick's going to push back a little bit. And so I've added one that I don't know whether I'm calling it a primary one yet. So I have it a little lower place. Rick, you'll forgive me, but Rick will present his view in a bit. But I am showing some citations. Literally, one of these citations is in cells, one is in rodents, and one validates this view in humans. The reason I still have it in its position is that I think it's through inflammation, because there's some evidence to show that if you inhibit inflammation in cells that are treated with uric acid, you resolve the problem. So I'm sort of putting it in this context through the lens of insulin resistance as some subset of inflammation. Rick, but I expect you to grill me and really let me have it later. Okay, now what about stress? I like to study, I actually teach endocrinology at a graduate level at my university. So I look at stress through the lens of hormones. And cortisol and epinephrine, or adrenaline, are the prototypical stress hormones. And these hormones have almost nothing in common. They come from very different cell types. They move in very different ways in the blood. They have very different effects on cells throughout the body. The one thing they have in common is that they both want to increase blood glucose. Cortisol especially. Cortisol will destroy everything else in the body to try to turn it into glucose. It's so determined. But naturally, as these two hormones are pushing glucose up, that puts them at odds with insulin, who's trying to hammer the glucose down. And so the longer there's this stress presence, if you will, the harder insulin has to work, and thus the cells or the body become insulin resistant. Now, with inflammation, this is actually much of my research into insulin resistance came from the origins of the immune system. And I know Sophia is talking later about autoimmune diseases, right? Sophia, you're here, right. Yep, so this is very relevant. What's interesting is that there are case reports in humans to show that as an autoimmune disease is flowing or ebbing, it's coming and going, as it will naturally kind of move, so too does insulin resistance. It will track very well with it. So suffice it to say, anytime inflammation is being turned on, like pro-inflammatory proteins called cytokines, then it makes the body more insulin resistant. And you may even detect this when you're sick. People who wear continuous glucose monitors, it can actually act as an early signal if they're fighting an infection, because you're becoming a little more insulin resistant in your glucose levels. You're having a harder time controlling your glucose. Some of the interesting inputs or stimuli to increase cytokines are ones that I've listed here. And my lab has focused a great deal on the inhaled particles, so diesel exhaust and cigarette smoke, not a great deal. We've published a few papers. But I'm going to come back to the adipocytes or the fat cells in just a moment. Now, with regards to hyperinsulinemia, this is one that is debated. A lot of people, they either don't understand it or they don't want to, or they don't think it can happen. But chronically elevated insulin is a cause of insulin resistance. And this is reflective of a fundamental biological principle. Any incessant stimulus will result in a resistance to that stimulus. The same thing goes for caffeine and drugs, that what used to be very sensitive and very responsive, you need more and more and more of it. The same goes for certain hormones, among them insulin. So if someone's living a life that is constantly spiking their insulin and keeping it elevated, that alone is creating an insulin-resistant state. Now, to add another dimension to this, and because we're all so interested in fat cells, I wanted to bring this to the fat cell for just a moment. Because if insulin is elevated, I don't want to overcomplicate this, but if insulin is elevated and there is sufficient energy in the system, fat cells have no choice but to grow. Or the fat tissue has no choice but to grow. But fat tissue can grow. The tissue can grow through two different mechanisms. One is through the growth of every individual fat cell, a process known as hypertrophy. The other is when each fat cell stays very modest in size, but there's more of them. The fat cells are reproducing. That's hyperplasia. This is what happens at the insulin injection sites of people who are treated, like type 1 or type 2 diabetics who are treated with insulin. If they're giving themselves insulin injections, you can see on the left the site of the insulin injections, how much bigger the fat cells are. So these were interesting studies where they did fat biopsies. So if I were giving my insulin injection right here, what they did is they tested the fat biopsy from that fat site, and they measured a site just 2 inches or 5-6 centimeters away. So the same overall fat depot, but at a different location based on where the insulin was coming in. And you can see on the left how the fat cells that were getting the incessant insulin therapy, they were 3 or 4 times bigger than the other fat cells were. So insulin is promoting a hypertrophy, and this is what it looks like when a type 1 diabetic isn't rotating injection sites. This is why a diabetic is told to rotate injection sites. Do it here one day, and then here, and then here, and then the arm. It's because insulin is so good at promoting storage of fat in fat cells that you have to spread it around so that it doesn't look like this. Okay, now, one of these is a healthy way to get fat, a metabolically healthy way to get fat, and that is hyperplasia. And let's talk through some of the reasons here. In this case, how am I doing on time? I'm just going to keep going. Okay, because I'm taking a little too long. We'll make up for it somehow. Okay, so when on the left, when a fat cell is becoming hypertrophic or big, it starts to reach a point of maximum size. But insulin keeps telling it to grow. Insulin's saying, fat cell, I don't care if you're getting too full, keep growing, keep growing, keep growing. But the fat cell knows that if it keeps growing, it will literally start to break apart. And so in order to survive, it starts to tell insulin, I can't hear you. And it becomes insulin resistant. This is sort of like an analogy of a hotel, where the small fat cells, so on the hyperplasia side, this is like a hotel where the moment the rooms get full, they just add new rooms. So they have 4 guests, or 4 guests per room. And then the moment those rooms are full, rather than shoving more guests in the rooms, they just make more rooms. Does that make sense? And so all of the guests are perfectly happy. No one is uncomfortably stuffed in a hotel room. On the other side, with hypertrophy, the number of rooms they have is set. And this is where most people are. Most people, we get fat through hypertrophy. It's uncommon to have dramatic hyperplasia. So in this case, there's no more room, but yet they keep pushing people in the hotel rooms. They keep packing them in, and now some people start sneaking off the balcony. That's what starts happening here. And so in this case, they start leaking, as I note at the bottom, the fat cell starts leaking free fatty acids. It starts breaking down its fat. Even though insulin's still forcing more guests in the hotel room, some are sneaking out at the same rate. And so it just prevents it from growing any further. I hope that makes sense. Now, a last point here is that fat cells, like every cell, they need a lot of blood vessels. They need to be very, very close to blood vessels to exchange gas and exchange metabolites and nutrients. But as the fat cells are getting larger and larger and more hypertrophic, they start pushing themselves further and further away from the blood vessels. And the fat cell becomes what's called hypoxic. It isn't getting enough oxygen. And so there's insufficient blood flow. And the fat cell, trying to stimulate new blood vessel growth, starts releasing some of these pro-inflammatory cytokines again. This has the effect of increasing inflammation throughout the entire body, but the fat cell doesn't care about the rest of the body. It just knows it needs more blood. And some of these cytokines can stimulate the synthesis of new blood vessels. So what's interesting about the 2 things I just discussed, one, that the hypertrophic fat cell becomes insulin resistant to prevent its own growth, but thereby leaking lots of fats, and 2, the hypertrophic fat cell becomes pro-inflammatory to try to stimulate the growth of new blood vessels. Both of these are things the fat cell is doing to survive. It just doesn't know that in so doing, it's wreaking metabolic havoc throughout the rest of the body. But this is what's happening, that as the fat cells have become hypertrophic, they're leaking fats in the form of free fatty acids, and they are leaking pro-inflammatory proteins. And that starts to spread problems throughout the body. Now, it also creates insulin resistance in the alpha cells of the pancreas, the liver, and the muscle. And this is when the person starts to push more into type 2 diabetes. And that will be a topic for another time, the relevance of these tissues, because it's very fascinating. All right, now let me end by just highlighting the solution. So far, this has been a horror story, right? I like to joke that we've been talking about the villain and exploring the villain's origins. Now we talk about how we beat the villain back. These are back to the 3 primary causes: stress, hyperinsulinemia, and inflammation. Out of these 3, I believe that focusing on insulin is going to have the best value. Because if you were to tell someone that their stress hormones are too high, and then they would get stressed, and they would say, well, how do I lower my stress hormones? And it's not so easy, because sleep can affect it. Relationship, anxiety can affect it. Similarly, if you tell someone, well, your inflammation is causing your insulin resistance, then they will say, well, how do I correct it? And you would say, well, I don't really know why it's high in the first place. So it's difficult, if these are 3 levers, it's difficult to get a very firm grasp on those 2, which is in stark contrast to insulin. We can grab insulin and change it very, very rapidly. So the key to improving insulin sensitivity among a handful is to lower insulin. You can do so by pharmaceutical use, so drugs, exercise, and the food we eat. I'm not going to talk about exercise because the simple story is just do something. So I won't talk about that so much. But with drugs, I just want to highlight it. Now remember, of course, I'm not a clinician. I'm not like Mariella, who actually is speaking to patients and prescribing drugs or de-prescribing drugs, as the case may be. I'm just a scientist. So this is the gospel according to Ben Bikman when it comes to drugs. And the ones that I kind of give a passing grade to in green, that I think the benefits can outweigh the harm, and then the ones in red where I think the harm is not worth any potential benefit. Now the interesting thing is about metformin. Metformin worldwide is the most used insulin sensitizing drug. And for good reason, it works pretty well. And the side effects are relatively modest. However, as good as metformin is, it is only half as effective as even modest lifestyle changes. And that's because, of course, type 2 diabetes and insulin resistance are not diseases that are caused by the lack of a drug. So putting the drug in the body isn't going to solve the problem. At their core, these are lifestyle problems. The food we eat is the culprit or the cure, and I'll end on that in just a moment. These are drugs that I give just a bad grade, F, or whatever the bad grade is in Israel, a 1 maybe? So very low score. One that I want to emphasize is thiazolidinediones, or TZDs. A TZD is a drug that you can give to someone with type 2 diabetes and insulin resistance, and it will improve the disease very, very quickly. What's so interesting about the drug, though, is that it takes hypertrophic fat cells and makes them into many, many more hyperplastic fat cells. And this is one of the reasons why I have a fat-first view, because if you just give them a drug to change the fat cells, they become very insulin sensitive. But can you see the problem with this view? They become very fat very quickly. And that's because the fat cells are just storing fat a little better. So it's a bit of a paradox where you are correcting the insulin resistance, but you're making them bigger than they were before. And then these last two are based on the view that glucose is the only thing that matters. Remember, to the average clinician, you're coming in once a year and they're just measuring your glucose. They have no idea what the insulin levels are. So the average clinician looks at this individual and says, that's a high glucose. We've got to lower that glucose. So let's just spike your insulin up even higher. And sure enough, it will lower the glucose. But the more aggressively we try to lower glucose with insulin, the faster people die. So putting a type 2 diabetic who already has high insulin onto a higher dose of insulin just makes them fatter and sicker than they were before. And what do you think happens to the insulin resistance? Remember, elevated insulin is one of the causes of insulin resistance. And so by pushing the insulin up even higher, you're making them more and more insulin resistant, which is why the dose of insulin has to keep increasing. Now, I'll be very brief here. Intermittent fasting, so when it comes to resolving insulin resistance, the food we eat is absolutely the key. Intermittent fasting is, despite being an ancient practice, it is still a fairly new scientific intervention. So there is not a lot of published research on this topic, but the little bit that exists is profound, where there can be remarkable improvements in insulin resistance very, very quickly by just controlling food. And of course, I would look at that and say, intermittent fasting is a wonderful way to keep insulin low, because insulin is the hormone of the fed state, the eating state. And if you're not eating, well, then insulin has no option. It has to come down. Now, the low-fat paradigm is, of course, the one that prevails. This is the one that gives us all grief, because we have friends and family who think we're crazy for saying fat is our friend, because they've been raised, as we all have, and they have maintained the view that fat is the enemy and carbohydrates are the key. So a low-fat diet is a high-carbohydrate diet. We have known for decades that this can be very problematic. One of the most famous type 2 diabetes scientists, which is to say nobody knows about him at all, but I do, he published this paper in the late 80s when he took people with type 2 diabetes and put them on the prescribed diet perfectly to the T, to the letter, to the iota of the American Diabetes Association, and they got worse. So and it makes sense, doesn't it? If you have a person whose disease is a hard time clearing glucose from their blood, why on earth would you put more glucose in their mouth when that's the one thing they're having a hard time with? It defies all reason. Now, a defense of the low carbohydrate diet, as I finish, I promise I'm very near the end, is to look at what happens to insulin when we eat the macronutrients. So these are the 3 macronutrients of the diet: fat, protein, and carbohydrate. When someone eats pure fat, there is no insulin effect. I know that this is debated on social media. I don't know the origins for that debate, but there is no effect. People say that there is, it isn't. Even the studies that they will cite will show something, but it doesn't ever reach statistical significance. So it doesn't change. Fat, I'm doing these studies in my lab right now, and it doesn't change. So fat has no effect. Protein it does have an effect, absolutely. But the degree of the effect will depend on the underlying glucose. This is something I've spoken about at a meeting before. And then pure carbohydrate will increase insulin. Of course, the degree of the insulin spike really depends on the nature of the carbohydrate itself. That, we all, of course, know that. Eating cauliflower is not the same as drinking a sugary soda pop. So, needless to say, the type of the carbohydrate matters enormously when it comes to predicting or determining what the insulin effect is going to be. But it's just, rather than, I was going to show a bunch of studies, but I took it out for time's sake. I thought I would just actually refer to the American Diabetes Association. I can't believe I'm saying that. But in 2020, they updated their nutrition guidelines, and I've highlighted this out of just pure giddiness on my part, noting that the best nutritional therapy for lowering glucose is a low carbohydrate diet. And why wouldn't it, right? It makes all the sense in the world. So the mountain of evidence has now reached such a peak, such a height, that now even these slow-moving bodies can't ignore it anymore. So, in conclusion, in this kind of whirlwind lecture, bless your heart, you translators, for keeping up with me, we've talked about what insulin resistance is, its origins, and even how to beat it back. You guys, thank you so much for listening, and thanks again for coming. Thank you.